them on the streets. New York City has a right to shelter that was litigated in the 1980s. It's essentially a shelter-on-demand city, and that has had some implications for the picture of homelessness in New York City. And to paint that picture a little bit, I wanted to do a baseline comparison with Los Angeles in terms of what their homeless problem looks like. In Los Angeles, at the same night that the count that I mentioned before was done in New York, there were 42,000 unsheltered people in Los Angeles. So a complete shift of ratio between sheltered and unsheltered, and about 14,000 who were in shelter in Los Angeles. And so that gives you a picture of one of the most important aspects of the right to shelter in New York City. We have a very significant homelessness problem, but people are under a roof, receiving services and receiving food. Some assumptions that I want to put on the table before I talk more specifically about the intervention that I want to propose, just so that you get a sense of kind of our experience in New York. Perhaps a better way of putting it is my experience in New York. If someone comes into your office and says, this is the one thing we need to do to end homelessness, stop listening. Homelessness is a complex, multi-factor problem. The woman who's living on a piece of cardboard on the floor of Penn Station has a different set of needs than the family being evicted from an apartment in the Bronx because they can't pay rent. They have a different set of needs from the guy who's being discharged from a psychiatric or correctional institution with no aftercare plan, no place to go, nobody to help him land in the community successfully. So what we really need in any homeless system of any sophistication is a toolbox with lots of different tools in it. And we need smart folks who are going to try to craft those solutions in a way that meets the needs of the individual or family who comes in front of us. What I want to talk about this afternoon with respect to an intervention is the link between homelessness and health care. The research literature is absolutely clear, and the research literature is absolutely supported by our 35 years of experience at Care for the Homeless serving the people that we serve. There is an inextricable link between healthcare and homelessness, between health and homelessness. Homeless people, Jim O'Connell from Boston has found, are 3 to 4 times more likely to die than the general population. Can you imagine a chronic illness that killed people at 3 to 4 times the rate of the general population, that the government did not wrap every resource possible around it to try to address? So 3 to 4 times more likely to die than the general population. Homeless people typically die 25 years earlier than the general population. I mean, this is a public health crisis in addition to everything else. Health crises very frequently precipitate episodes of homelessness. That is a very obvious connection, and it's very difficult to end an episode of homelessness if you don't address the healthcare issues that the person is experiencing. What we also know is that a person-centered, multidisciplinary, integrated care model delivers superior results to other ways of serving folks. I have enormous respect to people who go out and do street medicine and work on an urgent basis to try to help relieve suffering, but at the end of the day, what we really need to do is connect homeless people to integrated, multidisciplinary healthcare. And I hope in this little manifesto that follows that I will convince you of this as well. So this really is going to tell the story of how we and my colleagues and I, and I'm very proud that a number of them are here with me today, how we approach healthcare for homeless and unstably housed people in New York City. I'm not saying that we get this right completely every moment of every day, but these are our goals, and I think we do hit the mark more often than we don't hit the mark. So first off, we at Care for the Homeless use a multidisciplinary team-based approach. When you walk into one of our health centers, and we have 24 of them throughout New York City, you're going to have access to primary care, behavioral care, podiatry, optometry, in many cases dentistry and other modalities, delivered by providers and support staff who are themselves working as a team. This, we believe, and I think the data shows, produces better results than the fragmented healthcare that homeless and unstably housed people frequently get. It's extremely important to us to maintain, to establish, and then maintain continuity of care with the people that we serve. Our model of care at Care for the Homeless is to establish longitudinal healthcare relationships with our patients and provide intensive engagement through care management services, through outreach, which works side by side with the quality healthcare services that we provide. And so it's extremely important for us because many of the people we're dealing with experience multiple comorbid illnesses, we need to be providing care over the long haul. We want to establish a healthcare relationship with someone that does health improvement over time, not simply patches up the particular complaint they have on a particular day. One of the most important things for us, and one of the reasons I think to the extent that we have that success, is that we as an organization are focused like a laser beam on a mission of providing the care with dignity and respect. Our facilities and our customer service need to be provided at the highest level of quality. It's my expectation, and I know the expectation of all of my team, that every staff person who interacts with one of our patients at Care for the Homeless is focused on reducing the stigma of homelessness and poverty that the people experience, the people coming before us experience. We recently, in fact, to tell a small anecdote, we had a woman come to one of our health centers, needed a note for a child to go back to school the next day. I guess the kid had recovered from an infection. The doctor pulled out the prescription pad, says, little Johnny can go back to school. Hand the prescription note to the mother, and her face falls. And the doctor was flabbergasted and said, what's wrong? I thought I gave you what you asked for. And the woman said, the school doesn't know we're homeless. Now, I've done this work for a long time. That was a serious kick in the butt to me, that we are not doing what we need to do in every possible way to reduce the stigma of homelessness. And so we went through a soul-searching process, which was helpful. Then we went through a planning process, which was a lot more helpful, because we came up with a concrete solution to this problem. We liked Care for the Homeless, we liked the CFH concept, and we then rebranded ourselves as Care Found Here, CFH, retaining our acronym, but really communicating what we want to provide to the community without the stigma of you're not walking through the door of a homeless healthcare center, you are walking through the door of a healthcare center, and you happen to be homeless. Big difference. We want our team to be as diverse as possible, and to the extent that we can arrange this, we want our team to reflect the diversity of the people that we serve on every stripe, economic, racial, every possible variable that you can think of. We make certain that we give people with lived experience of homelessness a voice in our decision making. We have 3 people, I'm very proud to say, with lived experience of homelessness on our board of directors. We have an extremely active community advisory board that we engage not just in collecting information, but helping us improve the services. We work with them repeatedly over the course of the year, and some of the best ideas we have had in terms of improving our services have come from people who have experienced our services and have experienced homelessness. We really want to set up a situation where we'd be proud to have any one of our family members walk into one of our centers and get care. It's a concierge style medicine approach for people who are experiencing homelessness and who are unstably housed. We're very clear about the quality of care that we want to provide. We want homeless people to receive the quality of care of everybody around this table, or better, and we underline or better several times, because many of the people that we're serving experience chronic comorbid conditions. Many are living with hypertension, diabetes, asthma. Many have a co-occurring substance use disorder or mental health disorder, and they deserve the quality of care that all of us get, or better. We don't just assert this, we've also received some third-party verification of this. The National Committee on Quality Assurance has identified us as a patient-centered medical home level 3, their highest level of designation for providing services under the PCMH model. One of the important things that we're doing right now, executing a multi-year strategic plan, is trying to increase accessibility of care, and we're doing this in a very particular way. Homeless people, and as you heard Stacy's wonderful story, are transient. They move from place to place in New York City, sometimes by choice, but very often because the system is simply assigning them to different places. You may walk into an assessment center in one borough, get assigned to a shelter in another borough, get moved to housing in another borough. Really hard to maintain continuity of care under that situation of transience. And so what we've decided to do, kind of like in a go big or go home approach, is that we are establishing an ambulatory care network for homeless and unstably housed people in New York City. We want to make certain that we have a health center near where you are going to be so that you can come through a multi-year longitudinal healthcare experience with care for the homeless, and wherever you are assigned, there's either a care for the homeless health center in the place where you are living or nearby that we can provide that continuity of care. We're making real, incremental, but very real progress in implementing this. I would say that we're probably a year away from having this ambulatory care network fully established in the Bronx. We're working hard to establish it in Queens and Brooklyn, just starting in Manhattan. So making significant strides towards that goal. We need to do outreach and engagement. We can have the most beautiful health centers and the most highly qualified providers and support staff, and still if no one walks through our door, we can't help them. And so we've made a decision that we need to figure out how to do outreach and engagement that's at the same level of quality as the healthcare that we provide. And so we've assembled an outstanding team of peer outreach workers. These are folks who themselves have experience of homelessness. And we train them, and they go into places like shelters, soup kitchens, drop-in centers, permanent supportive housing programs, and they engage folks, make appointments in the health center, and get them engaged in care. If it's at care for the homeless, we're happy about that. It can be somewhere else. We're not proprietary about that. We want people to be engaged in care. We also take what we think of as a no wrong door approach to our healthcare. We are a multi-service center. No matter what you walk in for, no matter what's that first service that we provide to you, we want to make certain that we're meeting all your needs. So the example I like to use is someone walks in for a podiatry appointment and they're experiencing some peripheral neuropathy because of their diabetes. Well, the first question we need to ask after the podiatrist is done is, do you have a primary care physician? Are you connected and is someone managing your diabetes with you? And so we walk that person down the hall and make an appointment for them to see the family care doc in a week, or a nurse practitioner or an internist, to begin to work on the different issues that that person has at the pace that they want to work at it, but we want to be able to provide that service. We do intensive follow-up. Engagement is not just enough. Getting the person in for the first appointment is important, but we need to be working with folks to manage all of their different issues. And we're beginning to use some technological assistance. We're using text messaging, SMS, to remind people of appointments. One thing that I've learned over the years is that if you are unstably housed, particularly folks living on the street, your cell phone is your lifeline. That's one of the things that keeps you connected to the world. We can exploit that by using the phone to make certain that people are remaining connected to our health centers, and we're beginning to experiment with those kinds of things. We do extensive health education. We've got a population health program. We go into places where homeless people congregate, and we do flu vaccine clinics. We do pap test clinics. We do hypertension and diabetes education. And these educational events often then result in someone coming in and receiving an appointment. And finally, we're beginning to use technology in interesting ways. We, for many years, have had an electronic health record. That means that wherever you walk into, whatever node you are in the 24 health centers that we operate, that provider who sees you that day will know all the labs that have been done, with your permission, of course, all the labs that have been done, all the treatment that's been provided. And so you will have continuity of care no matter what node in our network you walk into. We're experimenting with a patient portal where you can make appointments through an electronic portal. We're giving people access to their healthcare records through a pilot that we're doing with New York State, so that you can actually, as the patient, go in electronically and see what is in your chart. And finally, we're beginning understanding how difficult it is sometimes to provide care even in New York City. We're beginning to experiment with things like telepsychiatry. And so we're trying to reduce the barriers to care by giving people, again, if they choose to and if they find this a useful way of receiving services, access to telepsychiatry, and we can cut down the waiting time between now and when you get that psychiatric appointment dramatically. So the intervention that I am attempting to sell you on this afternoon is the provision of integrated healthcare as an important tool, one among many, to solve homelessness.
Thank you.